Hi friends, greetings of the day. Now we will discuss about disorders of puberty, part 3. In previous two parts we discussed about precocious puberty. Now we will discuss about delayed puberty. Delayed puberty can be divided into three main headings: CDGP, hypogonadotrophic hypogonadism, and hypergonadotropic hypogonadism. CDGP is a constitutional delay in growth and puberty. Constitutional delay in growth and puberty. It's a physiological or functional cause. There is no any organic pathology. There will be a family history of delayed growth and puberty. Okay, and it means parents can be having a delayed growth and puberty. Attains puberty around 18 years. Normal age, normal maximum age for females is 13 years, and for males is 14 years. But these CDGP children can attain at 18 years or late. Okay, they will also have delay in growth. Okay, so there will be short stature. This is the differentiating feature from other causes of delayed puberty. Okay, there will be short stature. It's a differentiating feature, more commonly seen in girls. Okay, CDGP is more commonly seen in girls. Next is hypogonadotrophic hypogonadism, or primary or also called as secondary hypogonadism. Here the defect is in the synthesis or activity of the GnRH. Okay, gonadotropins, defect in the GnRH or gonadotropins like LH and FSH. So there is defect in the synthesis or activity of GnRH and gonadotropins. That's why it is called as hypogonadotropic hypogonadism. Name only says hypogonadotropic. Hypo means less gonadotropins. The causes are isolated hypogonadotropic hypogonadism, means there will be only defect in the gonadotropins. Whereas in combined pituitary hormone deficiency, there will be deficiency of all other pituitary hormones. In isolated hypo, there will be deficiency of only gonadotropins. Examples are Kalman Syndrome, Prader-Willi syndrome, and many other genetic defects leading to decreased production of the gonadotropins. There are many genetic mutations, and also Kalman syndrome and Prader-Willi syndrome are examples of the isolated hypogonadotropic hypogonadism. Next is combined pituitary hormone deficiency. It's also called a CPHD or hypopituitarism. Here all the pituitary hormones are deficient. Okay. Tumors like craniopharyngioma, other acquired causes are tumors like craniopharyngioma, infections like TB, infiltration, vascular conditions like Sheehan syndrome can have multiple hormone deficiencies and other defects associated with hypopituitarism. Okay, so isolated hypo only hypogonadotropic. Examples: Kalman syndrome, Prader-Willi syndrome, and many other genetic defects. Combined pituitary hormone deficiency and acquired causes like tumors, infections, infiltrations, and vascular conditions. Next is hypergonadotropic hypogonadism or primary hypogonadism. It is called as primary hypogonadism because the primary defect is in the gonads itself. That's why it is called as primary hypogonadism. But here it is called secondary because the defect is in the gonadotrope synthesis. It is called primary because primary defect is in the gonads. Hypogonadism, the primary defect is in the gonads. That is called primary hypogonadism. Okay, primary gonadal failure. So the gonads are only defective here. Primary gonadal failure. Here the testosterone and estrogen are not synthesized. Because of that, there is no negative feedback on the gonadotropins LH and FSH. There is no negative feedback because the testosterone and estrogen are not synthesized because of primary gonadal failure. There is no negative feedback on gonadotropes. This will lead to excessive secretion of the gonadotropes. That's why it's called hypergonadotropic hypogonadism. Examples of primary gonadal failure are Klinefelter syndrome 47XXY, Turner syndrome 45X, and in some acquired causes like infections, chemotherapy, radiation, infiltrations, etc., surgery, etc. Okay. Here there will be increased levels of gonadotropins because there will be no negative feedback from the testosterone and estrogen because there is hypogonadism. Okay, so there is primary gonadal failure. Okay. So these are the causes: CDGP, hypogonadotropic hypogonadism, and hypergonadotropic hypogonadism. So mainly delayed puberty is because of hypogonadism. In CDGP there is no any organic pathology, but this is a functional. They will attain puberty and growth, normal growth by 18 years. In this hypogonadotropic hypogonadism, there will be main problem in the GnRH secretion and the gonadotropin secretion, whereas in hypergonadotropic there will be primary gonadal failure, and various conditions we have discussed leading to these problems. Next we will come to the approach to delayed puberty in males. Okay, in males, first we will check the gonadotropin levels by basal LH levels and luteinizing hormone levels and GnRH stimulated luteinizing hormone levels. So if the basal LH and GnRH stimulating luteinizing hormone levels are high, then you know that if the gonadotropins are high, you call hypergonadotropic hypogonadism or primary hypogonadism. The defect is in the gonads, primary gonadal failure. The causes are Klinefelter syndrome in the males and other acquired causes. So to detect Klinefelter syndrome, you should do karyotype. If the karyotype is 47XSY, it is Klinefelter syndrome. The clinical features are long legs, gynecomastia, firm small testes. If the karyotype is normal, it is primary gonadal failure due to various acquired defects like surgery, infiltration, infections, chemoradiation, etc. So primary gonadal failure due to various acquired causes. If karyotype is 47XSY, then it is Klinefelter syndrome. Okay, so all the causes for male are ruled out. Okay, then if for hypergonadotropic hypogonadism, all the causes are ruled. Now if the gonadotropins are low, it is hypogonadotropic hypogonadism or secondary hypogonadism. Examples we already seen, that is Kalman syndrome and isolated hypo combined pituitary hormones or tumors. Okay, so to diagnose all these things, first we should see gonadotropins. If they are low, then it is hypo. Then you check the growth of the baby, if he is growth of the child. If he is short, check for the bone age. If there is delay in bone age also, then it is CDGP, constitutional delay in growth and puberty. Okay, short child with bone age delay, then there is CDGP, constitutional delay in growth and puberty. If the growth is normal, then check for smell. If the smell is absent or low, I already told you Kalman syndrome, there will be anosmia. If there is absent smell or low smell, then you do for MRI, there will be absent olfactory bulb. Then we can diagnose Kalman syndrome. In Kalman syndrome, along with the isolated gonadotropin deficiency, there will be absent olfactory bulb in MRI. So like that you can diagnose Kalman syndrome. If the smell is normal, do MRI. If MRI is normal, then it is isolated hypogonadism due to genetic defects. I told you various genetic defects can also call this hypogonadotropic hypogonadism, along with Prader-Willi and Kalman syndrome. Various genetic defects, genetic mutations of various defects, which help in the synthesis of these gonadotropins. There will be genetic defects. They will cause isolated hypogonadotropic hypogonadism. In this, the MRI will be normal. There is no absence of olfactory bulb. Whereas if in Kalman syndrome there is absence of olfactory bulb and the smell and smell is absent or low. So first, how to diagnose CDGP is do gonadotropins. If the child, then look for if the gonadotropins are low and check for growth. I already told you here a short stature will be there in CDGP. So this is a differentiating feature. So you should check the growth. If the growth is short, then it is CDGP. If the growth is normal and smell is absent or low, so next CDGP we finish, then we will come to causes of other causes like isolated hypo Kalman syndrome. So if the smell is normal, then it is isolated hypo due to various genetic defects. If the smell is absent or low and MRI is olfactory bulb is absent in MRI, it is Kalman syndrome. Okay, next, if the growth if the growth is arrested after spurt, Means now if the child attains the growth spurt, he attains the growth normally, but it will arrest due to acquired causes. So the growth will he will attain normal growth, but the growth is arrested at some age. Okay, like till 12 years he will attain growth normally, but after 12 years there will be arrest in growth. Then, and also the hypogonad, there will be hypo, there will be low gonadotropins. Then you check for MRI, there can be some ICSO, intracranial space occupying lesions like craniopharyngioma. Okay, there can be craniopharyngioma. Okay, if you do MRI. So here it is acquired cause, or there can be some vascular abnormalities like Sheehan syndrome or some infections. This can lead to the arrest after spurt. Okay, so this is the approach to the child for child with delayed puberty in males. Okay, next, approach to delayed puberty in females. Okay, approach to delayed puberty in females. Same, first we should go for gonadotropins, LH and basal LH and gonadotropin stimulating LH levels. If they are high, same like here, it is hypergonadotropic, same like here. Same, you should do karyotype. If it is 45x in males, Klinefelter we should rule out, but in females we should rule out Turner's 45x. The clinical features are short mental retardation, short stature, mental retardation, web neck, cubitus valgus. Okay, if the karyotype is 46XY, means the karyotype is like males, then it is called Swyer syndrome. It is the gonadal failure, gonadal dysgenesis. During the development only, the gonads will not develop properly. There will be dysgenesis of the gonads due to primary defect in the chromosomes, Y chromosome. There will be defect in the gonadal development only, primary gonadal failure, gonadal dysgenesis. In this, there will be no breast development and they will have amenorrhea. And in USG there will be sleek gonads and Mullerian structures. We will discuss about this in ambiguous genitalia, because the chromosome is male chromosome, but the patients will look like female. It is a type of ambiguous genitalia. So we will discuss in next video about the ambiguous genitalia in detail. So if there is a hypo, first you do karyotype. Okay, we discussed here causes of hypo or Turner syndrome, Klinefelter syndrome. Klinefelter syndrome you seen in males. Here you should check for Turner syndrome. And Swyer syndrome, don't confuse it. It is a female genotype, but the patients will look like males, and they will come with a delayed puberty and amenorrhea. It is a chromosome is 46XY, but they look like females. They will be grown as females, but they will come to you with delayed puberty and amenorrhea. In them, there is a complete gonadal dysgenesis due to Y chromosome defect. Okay, we will discuss in detail about this in the ambiguous genitalia chapter. If the karyotype is normal, then same like here, if the karyotype is normal, primary ovarian failure due to acquired causes like infections, infiltrations, tumors, radiation, surgery, etc. So this is a hypo in females. In females, if it is hypo, first same like there, check the gonadotropins. If they are low, it is hypo. Then same like here, check for growth. If there is short bone age delay, CDGP. If the normal, same like here, check for smell, absent, same like here. Same like males, it is same. Do MRI, absent or Kalman syndrome. If MRI is normal, it is isolated hypogonadism. Check for genetic defects. So genetic defects can be there, which lead to the defect in the production of the gonadotropins. Same like if there is arrest after the spurt, then do MRI. We can suspect the ICSO like craniopharyngioma or some infections, granulomas, infiltrations, etc. And there is another cause of delayed puberty in female. They are so same like Swyer syndrome, 46XY. Here also one other condition called complete androgen insensitivity syndrome. The genotype is 46XY. Okay, genotype is 46XY, but they are grown as females because their genitalia everything will be female. So they are grown as females. They will present at the time of puberty, with delayed puberty and amenorrhea. There will be normal breast development because in CAAS there is defect in the testosterone receptors. So testosterone will be very high, but it does not act on the receptors because there are defect in the testosterone receptors, complete defect. So testosterone will be very high, which these increased testosterone levels will convert into estrogen, leading to breast development. So normal breast development is the differentiating feature between Swyer syndrome and complete androgen insensitivity syndrome. Both will be having 46XY and they will be grown as females and they will present as amenorrhea and delayed puberty. But in complete androgen insensitivity, there will be normal breast development due to increased testosterone, which converts into estrogen. Because in Swyer syndrome, there is complete gonadal dysgenesis. There is no production of testosterone or estrogen, so there will be no breast development. Okay, but here the testosterone is produced, but there is defect in the receptors. So this high testosterone will lead to the conversion of estrogen and it will lead to normal breast development. This is differentiating feature between Swyer syndrome and CAAS. Here also the karyotype will be 46XY. Okay, increased testosterone will, I already told you, convert to estrogen, which leads to breast development. So other than the conditions which I told, in these causes, there are two conditions: Swyer syndrome and complete androgen insensitivity syndrome. Here the genotype is like males, but they are grown as females, present with amenorrhea and delayed puberty. Okay, in CAAS there will be normal breast development. In Swyer syndrome there is no breast development. Okay, other than these causes, remember Swyer syndrome and complete androgen insensitivity syndrome. Okay. Next, investigations. If you can come to investigations, we already discussed in approach. We should do gonadotropin levels, LH, FSH, and basal LH and GnRH, stimulated luteinizing hormone, and in CDGP children you can check for testosterone levels. Okay, 8 AM testosterone levels also. If the testosterone levels are just increasing, then you can wait. If they are completely absent, then you should go for treatment. So 8 AM testosterone levels. And karyotyping, I already told you to compare with Turner's, Klinefelter syndrome, Swyer syndrome, complete androgen insensitive syndrome needs karyotyping. MRI brain to detect Kalman syndrome and intracranial spatial appendages like craniopharyngioma, and inhibin levels. Inhibin levels will also help to differentiate between hypo and hyper. Next, we will come to management. CDGP children usually needs reassurance and observation. Okay, constitutional growth, because it is a physiological or functional cause, we should reassure the parents and observe the children. If the girls does not attain the puberty beyond 13 years and boys beyond 14 years, then you should go for treatment. In boys, you should give testosterone injections, and in females, you should give estrogen injections every month for 6 months. Okay, every month you should give for 6 months age. It's called kickstart therapy. It will help them to attain the puberty fast. In the maximum time you should give is in girls 13 years and boys 14 years. If they don't enter into puberty, then give estrogen injections in girls and testosterone injections in boys for 6 months every month. Okay, and usually they will, by 6 months they will attain 90%, 95% will attain the puberty. But if they don't attain, you should reevaluate for other causes before starting the next trial of the testosterone and estrogen therapy. So after 6 months you should reevaluate them to rule out other causes, because usually after 6 months of therapy they will attain the puberty. Okay. Next is management of isolated hypo combined pituitary hormone deficiency, Klinefelter syndrome and Turner syndrome. In all these conditions, primarily there is no production of the sex steroids, because in hypo also, hypochondriac hypogonadism also, because there is no gonadotropins, it will lead to hypogonadism, testosterone and estrogen are not produced because LH and FSH deficiency. Here also because of LH and FSH deficiency, testosterone and estrogen are not produced. Here also because primary gonadal failure, testosterone and estrogens are not produced. So in all these things, testosterone and estrogen deficiency is seen. So we should replace testosterone and estrogen replacement should be done. Okay. And in ICSOL like craniopharyngioma, surgery should be done followed by hormonal replacement. In CPHD, along with testosterone and estrogen, you should replace other pituitary hormones also. In surgery, if you completely resect the pituitary gland, you should first do you should also replace with all the pituitary hormones. Next, if these patients, if they want to have fertility, okay, means if they want children, if they want to conceive, the patients with delayed puberty, if there is no complete, if the patient present without puberty and testis is prepubertal less than 3 ml, then if they want to conceive, first you prime them with both HCG and FSH stimuli simultaneously should be given. Both of these HCG and FSH should be given. If they present without puberty, no signs of puberty, and testis is less than 3 ml, then both HCG and FSH should be simultaneously given to help in the growth of the testes and seminiferous tubules and spermatogenesis. If you give this HCG and FSH in pubertal and people who did not attain puberty, if they want to conceive, this HCG and FSH both should be given simultaneously. This will help in growth of the testes and seminiferous tubules, and spermatogenesis will be seen. If there is partial puberty, if there is complete puberty, both should be given. If there is partial puberty, first HCG alone should be given for 6 months. If no puberty at all and the testis is pubertal, both should be given. If there is partial puberty, first HCG alone for 6 months should be given. Okay, after 6 months also, if there is azoospermia, means no sperm production, then you should start with the FSH. You should start FSH also in patients who have partial puberty. But in patients without puberty and without any signs of puberty, both HCG and FSH should be started simultaneously. In partial puberty, first you should start HCG for 6 months, and if there is azoospermia, start FSH also. Child with amenorrhea, other DDs are hyperprolactinemia and hyper and hypothyroidism. So some children will come with amenorrhea alone. So in such children, hyperprolactin levels and hypothyroid levels should be seen. Okay. So this is the approach. Mainly it is divided into 3 headings: CDGP, hypo and hypogonadotrophic and hyperconanotropic hypogonadism. So in approach, we should rule out all these conditions. Other than this, there are two conditions like Swyer syndrome and complete androgen insensitivity. Here the phenotype is 46, genotype is 46XY, but the children will look as females. Okay. And investigations and management is mainly testosterone and estrogen replacement. Okay. And fertility, for fertility we will give HCG and FSH. So if you have any doubt, please comment in my inbox, and if you like this video, press like button and subscribe to my channel. Thank you very much.